Hey, good morning, everyone, and welcome to EuroNurse. I am your host, Vic Sidis. Glad to have everybody here. If you're watching us live, great. You're probably watching us on one of our channels. Except Facebook, I seem to be having some issues right now, so I don't know that Facebook is getting a feed. But oh well, that's their loss. If you are watching us on YouTube, hit the subscribe and the like button. If you're not getting our e-news, be sure to subscribe on MailChimp on our website. Speaking of our website, if you're watching us on demand, make sure you check us out on euronurse.com to learn more about the show. Best place to go to get information on the show. And all of our past episodes are up there. Yes, 98 episodes. This is episode 99. Hey, want to listen to us in your car? No problem. Be sure to go into our Euronurse Plus area where you can go and get our audio podcast on any of your favorite podcasting media. And July 29th, next week, we have our big 100th episode. That's right. You can join us, and we're going to be giving away those cards for Coffee on Us with EuroNurse. I've got them ready to go. So for every 10 people that show up, I will be giving away a card. So you have to be live to win. So make sure you get on the live feed. That's the time you want to watch our show live. We're going to have a lot of fun. We got our great experts showing up. We've got some sponsors from the show that are going to come up and talk about what they think EuroNurse means to them. I even heard the president of SUNA is going to send us something. So we'll see. We got all that stuff planned. And a lot of back, kind of look behind the curtains at EuroNurse, some information that I'm going to share with you. It's going to be a fun show, so don't miss it. And you can be a part of the show. If you want, you can send a quick video. Get your phone out there, record it. But if you're camera shy, just go ahead and send us a message. That's going to be on our website. Just click that that red link that says email, video, or message. It'll bring you to a video spot where you can send us a quick message or even a video. This week, we have our own Andrea Strong joining us, who's going to be talking about ERAS, enhanced recovery after surgery for prostate cancer. So we're going to go ahead and bring our experts into the show right now. Experts, welcome to the show. There we go. Hey, how's everybody doing today?
Good. How are you?
I hope everybody is staying cool out there. We've had some crazy weather. I live near Chicago, and it's been close to the high 90s, sometimes normally around the 90s. It's been a hot one, so we're just trying to stay cool. Unfortunately, my office is surrounded by windows. Luckily, I've got curtains that come down to keep it cool, but it's a little warm in here today with all the because it is a small area. But anyway, that's my problem, not yours. But I'm Vic Sidis, and I am the host of the show. Been involved in this business for 40 years and coming up on our 100th episode. So I'm going to bring in Lori to tell you about herself. Go ahead, Lori.
Good morning, everyone. My name is Lori Atkinson. I'm a certified urology registered nurse. I have been in urology for 26 years and currently working for a large urology practice in Geneva and Winfield, Illinois. And yes, it is hot. I was already out this morning, and it's just, even though it's going to get up to 90, which doesn't sound horrible for some people, it's humid. Very
humid. Yeah, the humidity is tough. Now, in a not so hot place, Andrea, our speaker, go ahead and introduce yourself.
Good morning. My name is Andrea Strong. I'm a practitioner. I've been working in urology since 2010. I started off as a nursing aide on an inpatient floor, and now I'm a nurse practitioner in the outpatient setting. So I've done a little bit of everything in urology. I'm also certified as a urologic registered nurse. I'm the educational director for the Society of Urologic Nurses and Associates, the Chicago chapter, and I'm on the board of directors for National SUNA. And Vic's right, it's nice and comfortable up here in Wisconsin. It's about 70 degrees, although we're getting a little bit of rain.
Yeah, that's a good point that you make. We all start out as something not as great as what we are now. You don't have to be a nurse to end up becoming a nurse, a doctor of nursing practice. You go into it starting out as an MA or, as an orderly. That's how I started out. So whatever gets you into healthcare, stay with it, because someday you might be on the show. All right, let's bring Andrea's slides in here and take it away, Andrea.
Thanks for joining me today. We're going to be talking about Recovery RX, nursing tips for prostate surgery. ERAS protocols, which are enhanced recovery after surgery. This is a part 2. There is a part 1 where we cover a little bit more of the basics. If you've never heard of ERAS before and you're asking yourself, oh, does my institution use this or not? I guarantee they are using this. It's already folded into current practices. But my hope for you today is that you can learn just 1 or 2 additional interventions that you can add on to help improve patient outcomes. All right. So again, what is ERAS, Enhanced Recovery After Surgery? It's basically a series of small interventions that can help improve the patient's psychological, physiological, metabolic state that can reduce complications and enhance recovery. The origins of ERAS. Interestingly, when I was doing some research for this presentation, I found slightly different answers depending on the source. However, from what I can tell, it started in the 1990s or perhaps early 2000s. There was actually a Danish surgeon named Hendrik Collette, and he first thought of some of these protocols to use in the colorectal setting. I just wanted to level the playing field here and cover some of the terms that we often use when we're giving these presentations to make sure that everyone is understanding. NPO means nothing by mouth. NG tube is a nasogastric tube, goes from the nose to the stomach, and that's designed to empty all of the contents of the stomach. Catabolism is a breaking down of molecules into smaller substances to use for energy. For example, when you're doing cardiovascular exercise, you're breaking down fat cells to use for energy. Antiemetics are anti-nausea medications. Analgesics are pain medications. IV fluids is IVF. POD is post-op day. The day of surgery is day 0. The day after surgery is post-op day number 1. Activities of daily living, also known as ADLs, is a patient's ability to bathe themselves, to wash themselves. An ileus is a post-operative complication that can occur when we give pain medications, when we give anesthesia, when we start disrupting the bowels or doing surgery in that area. It can stop the peristalsis movement of the bowels. The bowels should make a wave-like movement known as peristalsis to help move forward the contents. And oftentimes after surgery, that process is altered. Gastroparesis is a problem that generally happens with diabetes, although it can happen for other issues. This is when the food, once it makes it to the stomach, there's powerful movements that move it forward to the next step, and that can be altered. That's known as gastroparesis. LOS stands for length of stay, and this is a really hot button term for our administrators, for finance, for payers, because every day in the hospital means more money. I just want to pause and talk a little bit about the physiology of surgery. Psychological stress. Surgery is rated one of the most stressful events in anyone's life. Research shows, and yes, we've researched this, the stress levels start to kick up about 6 days before the surgery. Peaks around the time of surgery, and it takes several weeks for those stress levels to go back down to normal. Stress causes tachycardia, hypertension, elevated body temperature, sweating. It also causes immunological, hematological, metabolic, hormone changes. It can increase the sympathetic nervous system. This is your fight or flight response. And the hypothalamus pituitary adrenal axis. It can cause a strong inflammatory response. When they did some research on this, they found that patients who described very high stress levels prior to their surgery. They needed more intraoperative anesthetics to stay asleep. They needed more pain medications after surgery. They ended up staying in the hospital for a longer period of time and were at a greater risk for chronic postoperative pain. We often overlook the mind-body connection for patients, but this is huge. We see in the research that this is making a difference. So we don't have time in our urology offices to offer, cognitive behavioral therapy, to go over exercise regimens. So you can use some of your resources like your primary care doctors, or something as simple as recommending an exercise regimen or referring to a mental health worker can help in these areas. There's the physiologic stress of surgery. You come into your surgery, you're dehydrated, you're hungry, the physiologic stress of the anesthesia and the surgery itself. The ultimate goal is to avoid catabolism, avoid the breaking down of those molecules into smaller substances. And that catabolism can cause a loss of protein, loss of muscle strength, loss of cellular dysfunction. We can all think of examples when someone went in for surgery and then they become so deconditioned afterwards, they can't even go back home. They need to be referred to outpatient rehab. So before we talk about where we're headed, I want to talk about where we've been. And it's not pretty. These will shock you. In the past, we have recommended that patients be NPO for 48 hours. Can you imagine? Nothing to eat or drink for 48 hours, and now you have to go under the stressful life event of surgery. We also, in the past, have recommended bed rest for many days following surgery. That can increase risk of blood clots and heart attacks and pneumonia. At one point in time, it was pretty standard for most surgeries. Everyone got a nasogastric tube. If you've ever inserted one, seen one, had one, it's very uncomfortable. So we don't do that anymore, fortunately. They also used to recommend heavy opioid use. And I can remember not even that long ago when I was in nursing school, we were instructed to encourage the patient to take the opioid on a scheduled basis, because the thought was that if you waited until the patient's pain got too high, they would end up needing more narcotics than if they just took it around the clock. But the truth is that some people don't even need narcotics after surgery. And I'm going to talk in a few minutes here about some of the less risky analgesic options we have for patients. In doing research for this presentation, I found that there is actually an ERAS society. You can get more information at erassociety.org. To talk about ERAS protocols, it's easiest to break this down into 3 different stages. The first stage is the preoperative setting before the surgery. There's also an intraoperative setting. This is during the surgery. There's a postoperative setting after the surgery. We're going to start with the pre-op. Counseling. You will find that some organizations actually ask their patients to go through an educational session. Sometimes that's with a nurse, sometimes that's with an advanced practice provider. Some institutions will ask that the patient have an appointment with an advanced practice provider beforehand to go over the counseling and the expectations before surgery. Something interesting that I have noticed throughout my career, I used to care for patients on the inpatient side after surgery, and their biggest concern was often how to take care of their Foley catheter right before discharge. We referred to it as their leg bag teaching, how to take care of the catheter, how to switch it from the daytime bag to the nighttime bag. And I mean, all of the things that the patients have to worry about. And that was the piece that they were most concerned about. And of course, they wait till right before discharge. We're trying to do this education for them. There's new admits coming in. So my suggestion is to actually start talking to them about their Foley catheter, do their teaching beforehand. Show them what the catheter looks like. Maybe you could take a expired Foley catheter and actually use it to show the patient in clinic. Bowel prep. Bowel prep aims to empty the bowel of its contents of stool before the surgery, and it's often used for robotic cases when it relates to the prostate. If you think about how close those two structures are to one another, you've got your prostate right next to your bowels there. And there's different protocols depending on the institution. But I have an example of one. The day before the surgery, drink 10 ounces of magnesium citrate in the morning, and then do 1 fleet enema in the evening prior to surgery. Preoperative antibiotics. There are a lot of different protocols on this. The American Urological Association, known as the AUA, has some guidelines around this. You will often see some practices, if a patient has, let's say, a Foley catheter or a suprapubic catheter, they may have the patient come into the clinic, exchange that, send a culture out, not necessarily for a symptomatic urinary tract infection, but to see what their urologic system is colonized with. So if they have Pseudomonas, you can give one of the fluoroquinolones. That way you're targeting the exact type of bacteria that's growing. Interestingly, the giving antibiotics before surgery, the goal is to reduce infection at the same time preventing drug resistance, being good stewards of our antibiotics. And the guidelines state that the patients don't need to be on antibiotics for more than 48 hours after their surgery. If you're giving antibiotics for longer than 48 hours after surgery, it doesn't seem to have a benefit in preventing infections, and in fact can contribute to drug resistance. Prophylactic antiemetics. So if someone's had really bad issues with nausea and vomiting after their surgery in the past, they may benefit from getting those antiemetics ahead of time. Patient health optimization. We'll talk a little bit more about that in a few minutes. And then minimize preoperative fasting, which brings me to my next point, the new NPO. We no longer are recommending NPO after midnight across the board. These are new recommendations from the American Society of Anesthesiologists and new as of 2023. Gum is okay. Obviously, you want to take that gum out of your mouth before they go to intubate, but gum is okay. We also are recommending drinking carbohydrate containing clear liquids for up to 2 hours before the surgery. Again, that's 2 hours before the surgery. The patient can be drinking. There, unfortunately, is not enough evidence yet to recommend protein drinks prior to surgery, although I think the risks of protein drinks are relatively low. And here's a breakdown of the new guidelines. You can have a large meal up to 8 hours before surgery. You can have a light meal up to 6 hours before surgery, and clear liquids up to 2 hours before your surgery. Now, here's the caveat. These guidelines don't apply to everyone. If someone's at an increased risk of aspiration, then perhaps these new guidelines aren't appropriate. So use your clinical judgment. But those who may be at risk for aspiration, anyone with reflux, hiatal hernias, gastric bypass, gastroparesis, diabetes, opioid use, pregnancy, and obesity can all increase risk of aspiration. Carbohydrate loading. So what is this? Research has found that it can stimulate return of bowel function, reduce the incidence of an ileus, reduce the patient's length of stay in the hospital, reduce the catabolic response, and reduce post-op nausea, vomiting, and reduce that really strong feeling of hunger during that surgical period. So there's great evidence for this. This is one protocol that I found out there. And in fact, most institutions will provide their protocols. You can just Google it and look it up. Some are using Gatorade, some using Powerade, or a juice. Remember that these juices should not be red in color or dark in color because that could be mistaken for blood during an operative case. But here's an example of one. Purchase 36 ounces of 100% pure, no sugar added, white grape juice with no substitutions. The day before surgery, after dinner, drink 24 ounces. And then the morning of surgery, you drink 12 ounces of this juice. And that can help prevent bad outcomes for the patient. All right, patient health optimization. If someone has diabetes, let's get their hemoglobin A1C under control. That's not necessarily urology's job, but we use our partners to help make sure that that's well controlled. In fact, some surgeons have a threshold on where their hemoglobin A1C needs to be prior to surgery. Stop smoking. Avoid alcohol prior to surgery. Cardiovascular risks, make sure they don't have AFib. If the patient has heart failure, make sure that their regimen has been optimized already. Anemia needs to be handled before surgery. Good nutrition, carbohydrate loading, and prehabilitation, not rehabilitation, prehabilitation. Again, we see so many patients when they're in the hospital after surgery, they become so weak and deconditioned that they can't be discharged home. They have to go to an inpatient rehab. Well, we can prepare them. We can prevent that before surgery. Patients can do this on their own. It's not rocket science. Maybe they start walking more. Maybe they start a weightlifting program. Maybe they improve their diet. Or you can absolutely refer them to physical therapy before their surgery. This is a little bit of information that are more for someone who is working patients up for surgery in that preoperative setting. I want to take a look at their ADLs. If someone's not able to bathe themselves, if they're not able to dress themselves, they are at a higher risk of surgical complications. Do they have an exercise regimen? Do they have ambulatory aids? There's some evidence-based tools out there that can help us. One is the Duke Activity Status Index. And this is a screening tool that asks a series of questions that can help estimate the patient's metabolic equivalence, or METs. And that gives us an idea of the risk factors for them undergoing surgery. A score of 4 or less indicates they might need additional preoperative testing. They might need a stress test. They might need an EKG. Smoking and surgical complications. It takes 30 seconds to talk to someone in your clinic about preventing surgical complications by either stopping smoking or even reducing the number of cigarettes. Smoking before a surgery delays healing, increases risk of blood clots, heart attacks, infections. It increases risk of needing postoperative ventilation. It's harder to take patients off that ventilation after surgery if they're a smoker. It can increase inflammation. It can increase pain as well. Whenever I have someone in my clinic who's a smoker, I always mention, just so you know, that increases your risk of bladder cancer. So if you ever see blood or have microscopic blood in your urine, please come back to us and let us know. And if you have a male patient, inform them that smoking causes erectile dysfunction. That is a very effective way of getting people to stop smoking. I've had young men just about fall out of their seats when I tell them that smoking can cause erectile dysfunction. There's a few resources I have here on tobacco cessation. You can always refer to primary care doctors. There's a smokefree.gov that has some information. There are a few apps. Well, there's probably many apps, but these are two that I found in the literature, and that is called Quit Guide app or Quit Start app. Alcohol. This was some interesting research that I found, especially for those of us up in Wisconsin who like to have a few beers after work. But they found in research that short-term abstinence, which I thought short-term might be 2 or 3 days, but they're calling short-term abstinence 2 to 4 weeks before surgery. No alcohol. And that's been linked to a lower likelihood of postoperative complications. Abstinence for 5 to 6 weeks after surgery is recommended to reduce complications such as delayed wound healing, infections, and the patient's cardiovascular risk. Now we're going to talk about that intraoperative phase. Minimally invasive options. I think urology has done a great job with this. We don't have to do simple prostatectomies anymore for BPH. We have UroLift, we've got aquablation, we have so many different modalities available to patients. Reduce the use of opiates. There are other medications. We can use lidocaine, we can use Marcaine, we can use Tylenol to help reduce these patients' pain. This piece is a little bit more for our anesthesia colleagues, but you want to keep their blood glucose, body temperature, fluid volume relatively normal during that case, and use of regional anesthesia. I actually talked to a colleague who does robotic prostatectomies, and his patients receive no narcotics. Again, that's no narcotics. They're using regional anesthesia, so a local block, 20 cc's of 0.25% bupivacaine mixed with 4 milligrams of dexamethasone. The dexamethasone is there to help that bupivacaine work better. And that is used during the case. After the case, the patient receives a combination of Toradol and Tylenol on a scheduled setting. They never need narcotics, and their pain is very well controlled. Early removal of drains, tubes, catheters can all help prevent complications as well. All right, we're on to the third part of our ERAS protocols, and that is the postoperative setting. Quicker oral intake. We found that quicker oral intake can actually stimulate bowel function and prevent complications. This was interesting to me because it's been a while since I worked on the inpatient setting, but there was such a fear of advancing the patient's diet. And we're moving away from that a little bit. In fact, patients are getting usually clear liquid diets right away after surgery. Early mobilization. Many times patients after prostate surgery, if they're going to be inpatient, they come from the PACU, they wheel them up, they park them outside of their room, and they need to stand up, walk into their room. We go and do an assessment. They get their clear liquid tray, and then they need to get up and start walking laps around the unit. It's a shock to some patients, but it's absolutely necessary to promote healing and to prevent complications. Incentive spirometry. This is a tool that's used in the inpatient setting. These are these little blue pieces with the mouthpiece that helps inflate the lungs, expand the alveoli, and prevent pneumonia. Using the multimodal analgesics, we've talked about that already. Discharge planning. Does the patient understand their discharge instructions? Can they read? Are you giving them materials, written materials, and they can't even read? Maybe they need pictures. Do they have the proper transportation to and from their post-op appointments, to and from the hospital? And then your post-op appointments, make sure that they understand this catheter. You're going to be getting this catheter out on post-op day number, whatever that day is. These are your next appointments. So before I move on to the pediatric session, that sort of summarizes all of the main ERAS protocols that I found in the literature. So I want to give the audience an opportunity to share their ERAS protocols. Maybe there's something that I didn't mention. Maybe you have something to add to share with the rest of us. So please put that in the comment section now, and then we'll revisit that after I talk a little bit about the pediatric session. So I did some research into ERAS protocols in the PED setting. Unfortunately, it's not widely adopted at this time because the patient population is so specialized. But there have been some studies. They looked at ERAS protocols in pyeloplasties, hypospadias repair, bladder augment, and nephrectomy. And these are some examples of ERAS protocols that I found for children. Clear liquid or carbohydrate load, avoid too much salt and water to prevent fluid overload during the case, minimize the bowel preparation. They're getting usually clear liquids on post-op day 0, so that's the same day of surgery, a regular diet on post-op day 1, removing IV fluids on post-op day 2, and then you can potentially stimulate GI motility by chewing gum. Of course, that needs to be at the appropriate age. Vic, do you have any information from our viewers adding to the ERAS protocols?
Have not seen any comments coming through.
Okay. All right, so I just wanted to highlight a little bit of the research that I found regarding ERAS protocols specific to prostate surgery. This is on radical prostatectomies. Research has found that using the ERAS protocols resulted in a reduction in the length of stay, the time to flatus. So that's actually a fart. We're always asking patients on the inpatient side, have you farted? Have you farted? Have you passed gas? And it sounds kind of weird, but that can actually indicate the return of bowel function. So that is important. Time to first defecation, time for ambulation, and the time to remove the drainage tubes. And they were looking at specifically cancer patients and that have had a radical prostatectomy. Using ERAS protocols for radical prostatectomy also resulted in less complications. So at this time, I want to do a call to action. It does take about 15 years for evidence-based practice to go from the research to the bedside. Nurses, advanced practice nurses, medical assistants, and everyone in between plays an important role in this. It takes 30 seconds to tell someone they should stop smoking before their surgery. It takes 30 seconds to tell them they should be avoiding alcohol about a month before and a month after their surgery. Giving people tasks that they can do before surgery also enhances their feeling of control and their ability to participate in their care. So I want to thank everyone today for joining us for this presentation on ERAS protocols. Thank you. Vic, I think you're muted.
So great job is what I said.
Thank you. I appreciate that.
I'll kick it off so people can start getting their questions in here. I was really surprised when I heard about the grape juice, drinking grape juice ahead of that, white grape juice. I really was thinking that'd be great, long as I could ferment my grape juice and turn it into wine. And then I got the alcohol part, and I'm like, oh man. So there goes that idea. A lot of people, I don't think, really understand the smoking, how much of an influence that can have on wound healing, etc. To the point, I know that some physicians won't do elective surgery on smokers.
Right. There are some institutions that will actually check your blood for nicotine. And if it's positive, they're canceling your surgery. Yes.
Have you seen any of that, Lori?
Not so much. One of the things that I wanted to say is that we do definitely veer away from pre-op antibiotics now. Although we do require urine cultures within 2 weeks of surgery on many of the urology procedures. That way, either, if they're infected, we can treat it prior to and still have time to treat it so they could still proceed with surgery, or if necessary, cancel and reschedule. And you'd be surprised at how many people that we have probably previously brought into surgery that have had infections. And so the infection rate really reduced afterwards after we started doing that protocol. And I think it's an AUA standard now.
Mm-hmm. Yeah, that's a good point. So, Andrea, who's really the main person in charge of ERAS and implementing it? Is this the physicians, the nurses, the hospital? Who's everybody? What's your thoughts?
Right. Right. That's a great question. And it's going to vary depending on the setting that you're in. But ultimately, we're all responsible for this. Everyone is responsible for these protocols. When I was working as a nursing assistant, for example, on that inpatient floor a long time ago, my job was to get the patient up and get them walking. We had the whiteboards. I would put little check marks. These are your goals on the number of laps that you need to do, and helping patients with that. So ultimately, it's everyone's responsibility to do this because it's a bunch of different disciplines. It's in the preoperative setting. So it's, for example, someone like me who's working at the bedside. I am the one talking to the patients often about surgery beforehand. So that's my responsibility. It's the responsibility of the surgeon to make sure that they're offering minimally invasive options for the patients. It's the responsibility of the pre-op assessment team. They're looking at those metabolic equivalents, making sure that the patient's optimized. If they need additional testing, sending them for additional testing. It's also our intraoperative anesthesia team to try to have some homeostasis during that surgery, make sure there's not big temperature swings, make sure their fluid volume status is normal. And then it's our inpatient nurses, our inpatient team, get them up walking, advance their diet, educating the patient on their discharge planning. And again, back full circle, back to the outpatient clinic in preparing those patients and, for the best outcomes for them.
Yeah. Do you have any kind of written guidelines that you implement or something that you hand out to patients?
We have a lot of written materials that we use for patients. These are, if you're familiar with using the EPIC program, that's the program that we use. We have dot phrases, also known as smart phrases. So you don't have to write the same thing over and over and over again. You can just put that into their after visit summary. You can send it to them on MyChart messages. And of course, talking to the patients about it verbally in the clinic. We know from research that if you're just talking to the patient, they're only getting 10% of what you're talking about. So it needs to be more than one method of communication. So written and verbal, perhaps a video, perhaps some pictures. And you need to tell them more than once. Because as humans, we're just not great at retaining all this information. Also, it's a scary setting to be talking about surgery. Those anxiety levels go up, our ability to retain information goes down. And as our anxiety levels go up, our threshold for pain changes. We feel more pain the more anxious we are.
Yeah, because I was kind of thinking of that might even, as you know, I have the Europatient podcast that comes on after this show at 10:30. I know, a helpless plug, but I almost think that it reaches a large audience of people. I think that it'd be nice if we could do something along this line at a patient level, but I think something that had some kind of easier one step by step what you should do to prepare for your surgery. So maybe we can come up with something along that line and put something out for patients, because you're right, you have to hit them everywhere in multiple ways, video, handouts. You talked about 10% compliance. Now, I do most of what I do now involves with prostate biopsies, and
Mhm.
came up with the guidelines years ago of what I wanted patients to do ahead of time. Really follows a lot of your ERAS steps. One of the big things I always put down on the big paper they take home with all the information is eat, EAT, not don't eat. I tell them to eat before the procedure, because the biggest complication that I have is diabetics who go ahead and fast, take their insulin, and then drop their sugar right at the time of the procedure. So I've really made a point of trying to stress it. And I still to this day have patients who come in. I'll say, "Did you have anything to eat?" No. Like, it says right there, so we assume that even though we wrote it out, we told them and we gave them a handout, that they're going to read it and they'll pay attention to it. I find that patients will not. I think, as we have talked in our practice, I mean, on Euronurse, dogma rules. People are used to what they've been
Yeah.
doing.
Right.
Any thoughts on?
I have
Yeah.
patients who come in for a cystoscopy. I tell them you need to eat. I give them a piece of paper that says you need to eat. Our nurses call them a few days beforehand and they say you need to eat. And
Yeah.
so many people will come in for their cystoscopy Oh, I had nothing to eat or drink after midnight because I thought that was what it was supposed to be.
They're just
And
trying to be
then
good little patients, right?
right, right. And then they're more likely to have a vasovagal episode. They
Yeah.
turn pale, they start sweating, they start passing out. And I mean, we see that all the time in urology. But yeah, it's to your point.
Vasectomies. Vasectomies
Yeah.
Vasectomy.
especially.
Yeah, I mean, even the people that aren't diabetic, I mean, your blood sugar is gonna if you go and you don't eat, your blood sugar is gonna drop. You're gonna have,
Yeah.
a shift in volumes. I mean, it's just you're not gonna feel good. You're, as you say, more prone to vasovagal, which, um, for those that are not that are patients watching, this means that you're gonna pass out.
Yeah.
So,
Yeah, it takes a while to recover, and it can be really dangerous if you fall and if you hit your head.
yeah.
I mean, you're gonna have to go to the ER to get a workup. So yeah, it's really important to educate the patients. We're very fortunate in our setting that we have enough staff that our nurses are able to call patients a few days before their procedure to again review this information. Not everyone has access to that, unfortunately. But Vic, I think, your Euro patient is a great resource that a lot of us could just
Mhm.
use to say, hey, you're having this surgery. There's a lot of things that you could do that are easy. I mean, as you can see, these ERAS protocols are not fancy schmancy. They're not super expensive. They're small things that the patients can do and the staff can do to help reduce complications. And that'll be a great resource for our patients.
Yeah. And the point is these recommendations were based on actual research. They looked
Yeah.
into how long people have to have, no fluids in their stomach because there was always the fear of aspiration, during a procedure. And that's where the NPO after midnight started. Even if you had a 4 p.m. procedure, there was just no logic behind it.
Yeah. Vic, you have so much experience in this area. Do you remember some of the old operative practices that
Oh,
could be?
I mean, when we started out, I'll go back to early on when we did prostate biopsies. Our protocol was to put everybody through the go lightly bowel prep, the one that you take for colonoscopy, that stuff you drink down that's gonna, have for those of us that have gone through that, it'll come out as clear as it went in. It's terrible. I mean, and you feel, just so dragged out after you go through that prep. And that was just years ago because they thought, got to have a clear bowel prep. Nobody did research to see whether that was necessary. And I actually was speaking. Now currently what we do now is a Fleets enema. So it's just that little mild washout. Really, for most people, causes minimal. They put it in, it comes out almost as fast as you put it in. And really, the only thing it's treating in my eyes is people that really have chronic constipation that may prevent us from getting the probe inside the rectum so that we don't have to cancel them. And I was talking about this at an international group, and the folks from across the pond, the England, were saying, "You guys are crazy." I said, "Why are you putting people through an enema? Even that's ridiculous. We would never do that." I said, "Yeah, but you guys also have vacations called holidays where people don't have to go to work." I said, "Here in America, you miss work, and that's really important to people. So if I say, 'Oh, sorry, you're canceled because you're constipated,' they get upset." I said, "That's why we do a Fleets enema." But I think that's a good example of some of the dogma that's been going around forever without any research.
Yep.
And that's what you get from the being here for years. You'll find out, Lori. And I know you've got a lot of experience, but someday you'll have even more.
Yeah.
Uh, the other thing I thought that was interesting is the gum chewing, because that was always you can't have patients chew gum because it stimulates more saliva. Like that fluid is coming from magic land, right?
Yeah. Yeah. It is interesting, these new protocols. I think it'll help people. I think it'll really, I mean, I know I feel grumpy if I don't get breakfast. I feel
Yeah.
depleted if I don't get breakfast. And if I'm going in for surgery, in the stress levels of that, I just can't imagine how uncomfortable that would be
Yeah.
to be arriving so depleted for your surgery. So hopefully this will really help us out.
And I think just the chewing gum, going back to when you are fasting, that kind of satisfies some of the hunger. because it's
Yeah.
it's releasing some endorphins. And I talked about the circumcisions and how they use the pacifiers to try to calm these kids down. And I think it makes a huge difference if you can chew gum rather than taking everything away from patients.
And cutting
Yeah.
down the smoking.
Yeah, right. We really got
Yeah.
crabby people. I can't drink for 2 weeks before surgery. I got to quit smoking, and I can't eat or even chew gum. No wonder.
Right.
Let's see. I had another thing I was trying to remember. I know what I was going to talk about. The change in pain relief.
Yeah.
Back in the day, I had 2 major back operations in my life, which thankfully I went through those. But when I came out of this was in 2016, so right before they really started cutting down on the opioids, they gave me a prescription for 100 Vicodin to go home on. I think they wanted me to be Dr. House, just chewing away at Vicodin anytime I felt bad. And I don't like the effect of narcotics, that kind of groggy feeling that you get from it. So I can tell you what I did for my own, and this was, I had a laminectomy. I mean, it was major back surgery. I just went on Tylenol around the clock. And if you stay on Tylenol, and people say, oh, Tylenol doesn't work and it doesn't work. But if you get on it around the clock, you can't treat severe pain with it, but you can prevent pain by staying on Tylenol. So I think those are some good ideas that you had mentioned about that round the clock Tylenol. Even my wife had a knee replacement, never took one narcotic. They did, as you had mentioned, that block. They gave her a block in her knee, and she walked to the car right after the surgery to get into the car, because she's like, how am I going to get in the car? And they said, walk. You got a new knee. And she said it was pain-free. And I started her on the Tylenol around the clock right away. And the block, I think, worked for about 24 hours. So she didn't really feel much after that, but she never took anything else. I mean, she's pretty stoic, but the Tylenol did a good job. So I think it's really changed the way we treat pain.
Right. Opioids can also contribute to falls. Falls
Yeah.
are a huge complication. We see that in the inpatient setting. We see it at home. I mean, if you fracture a hip, I don't remember all this stats from the research, but if you fracture a hip, you're more likely to have all kinds of complications. It can shorten your lifespan. So yeah, avoiding the narcotics is really key.
Yeah. Let's not forget the post-op complication of constipation, which leads to retention, which really, I mean, it spirals.
Yes. A lot of people don't realize that urinary retention can be caused from constipation.
Yep.
So thanks for that.
I will have some patients in my clinic. We see it a lot after orthopedic procedures, that post-operative urinary retention. And if they come in and they say, I'm really constipated, I haven't had a bowel movement in days, I can feel it right at the end of my rectum, I don't even try a fill and void that day, because they're going to fail. Or maybe they'll pass and go home and then they can't pee. Got to get that under control, because that can absolutely cause urinary retention. Yeah.
Yeah. And you're right. So the opioids and the lack of activity is going to be a guaranteed constipation issue.
Yeah.
And I've had patients tell me the constipation was worse than the surgical pain. So, word for the wise.
That's funny. I just had a blood draw the other day, and removing the Band-Aid is way more painful than the actual getting the needle in your arm. It's so funny. I always just say, like, just let it bleed, because that Band-Aid hurts worse than anything.
What I have them do is because the adhesive bothers me too. I'll sometimes break out from it. So they use that, I can't remember, that brown stuff that sticks to itself.
Coban.
Coban, thank you. I tell them, just put a Coban dressing on it. And they're like, oh yeah, we got that in here. And so they just put a wrap on it so that it doesn't bleed, and easy to take off. But you're right. Yeah, that's the worst part. Sometimes peeling a Band-Aid. Well, it's great. We don't have any comments from the audience, so we must.
Well, we do have comments that everybody thinks you did an awesome, excellent job, Andrea. So good job.
Well, of course. It's always great to have, when we have our own experts on the show too, to talk about these subjects. So I think, as long as we don't have anybody else coming on here, I'm just gonna put a plug in. I don't have a video like I normally have our promo for the next week's episode because it's our 100th episode. Enough said. So we'd like to really try to get a lot of live audience participation. Looking forward to trying to have you guys ask us questions. Feel free to ask our experts whatever you want to know. I've got some questions lined up myself to try to get things going. And we're going to have some of our sponsors that sponsor the show on so you feel free to ask them whatever you want. And like I said, we're going to try to get I think Glenn Sully from SUNA, the president of SUNA, is going to try to get us a presentation for us. It's I've got some clips from previous episodes that I'm going to share that should be kind of fun. But anyway, you definitely want to join us for next week. Next week's all about fun. You may not learn anything. Maybe you will. Maybe you'll learn about us a little bit more. But I think it's going to be a fun episode, and such a treat for me to have been able to do this with you guys. I mean, every week after week, going and visiting, folks that I could tell you, we would see each other probably at meetings, and that would be it. Meeting John Lynn, I probably never would have met him in my life, and we've become like best of buddies now with our kind of common thing with doing these podcasts. Plus a number of physicians and healthcare workers around the country and even beyond the country. We had somebody who spoke from Canada for our group. So it's been really a pleasure of mine to be part of this, and the audience for being here, because it's fun to do this, but if nobody's watching, what's the point? But I think in people learning more about healthcare. So you join us and celebrate for our 100th episode with us. And I am going to put one last plug in for Patient coming on at 10:30. Got a real interesting talk on Botox today for that. And otherwise, hey, everybody have a great day, and we'll see you all for our 100th episode next week. I see a couple quick comments coming in. So wait a second before we go. Sorry, I walked away from it. Monica, you can never walk away from the show. She did ask, any tips to help with post-op constipation other than increased mobility, hydration, and decreased use of opioids? That's a good one. Andrea, you have any thoughts on that?
Sure. Always start off with things that the patient can do that are low risk. So obviously hydration, healthy fruits, healthy vegetables. There's actually a cereal that I will often recommend to patients. I have no partnerships with this cereal company. I make no money from this cereal company, but it's called All Brand Buds by Kellogg. You can find it at most grocery stores. It doesn't taste amazing, but it has lots of fiber in it. So I'll recommend to patients you can sprinkle this on top of your toast. You can sprinkle it on top of a yogurt parfait, or even add it into some of your other cereals, and that'll help deliver some fiber. We usually send patients home on stool softeners after surgery. And there is a fear of a lot of patients are afraid to use those. So encouraging the patient, don't be afraid to use these. At this time, we're working against the effects of the anesthesia. We're working against the effects of perhaps some of the opioids that were needed to be used for the procedure. So don't be afraid to use it. If you start having loose stools, then you need to pull back. But just educating them to avoid some of that fear is important. And then as far as avoiding the opioids, one thing you can do is talk to them about ways of stress reduction, because stress levels, anxiety levels decrease our threshold for pain. We can use cognitive behavioral therapy, not necessarily in our urology clinics, but we can refer to use for cognitive behavioral therapy, exercise, sleep hygiene, things that have some science based behind them. And then use any of your other options that you have. So you can do nerve blocks. You could try epidural anesthesia. I've even seen topical lidocaine patches used for some patients. Even something as simple as massage therapy or music can reduce and help soothe some of that discomfort that the patient's having.
Yeah, great thoughts. We used to do shot glass of mineral oil for patients back in the day to take as a prevention for preventing constipation. Not the most pleasant tasting. It's like drinking oil, but we would do that. I can remember castor oil used in the old days. Again, now you got fishy oily taste, but more pleasant. I think some of the ones that you brought up. And Monica did fill us in that she did thanks for the all brand. And the reason she left the show was her breakfast was burning. Well, now I guess we don't want to feel bad. Don't want you to burn your breakfast, but okay, folks, we'll see everybody next week for our 100th episode. Have a great weekend. Enjoy the heat and stay warm, cold, cool, whatever.